like a good presentation. She should just give hers.
No, it was so cool. So happy about that.
So we'll go ahead and get started. But before we get started, the second part, which is Lynn Johnson, she's a person that works for Standard Insurance Company. So we're going to talk about disability insurance. That is something that she is the representative for the University of Colorado. So she essentially is responsible. So Standard covers, as a company, us as faculty, but also covers residents GME-wide. So she'll talk about pros and cons of disability insurance, but the more important part is really understanding what do you do when you finish. Do you take some of your resident insurance that you have currently? Do you get your own? Pros and cons of those things. How much do you get? Those sorts of conversations. So that's going to be the second part. You'll see her scroll in, and I think she's going to work on this whiteboard, so I'll get that set up as well.
So she does partially cover residents who have left?
Yeah, so when you're a CA3, so now, you'll want to, over the next 4 months, usually before May, you want to have conversations with her, and she'll schedule either one-on-one appointments or group appointments to talk about whether you want to take your standard account with you when you leave. And so she'll be able to give you what that premium is. It's locked in. There's no medical tests that need to be done. You essentially just carry that forward.
And
She
she's
already
like
have
a
the
non.
on stay.
She works with G.
If you already have your own, yes.
Okay. Is it okay if we leave? If we already have our own?
Yeah.
Okay.
Yeah, you don't have to pick it up. But I think she's a valuable resource to say, hey, well, this is actually another plan that I was either thinking about doing or that I currently have. What are the pros and cons of this particular plan? She doesn't make any commission or anything.
She works for GME. She used to be like in the industry, but now she works for GME, and her job is to help residents with this. So she is like truly, she has your best interest.
Yeah. So I've utilized her for ever since I was a resident. She's fantastic in that regard. So very knowledgeable, sometimes a little bit too much information, so I'll try to moderate things as we go along to make sure it's not too much in the weeds. All right, go for it.
Perfect. So welcome. You guys all know me. I clearly have no personal financial disclosures, and then this is the usual disclosures that go along with these M&M or case review conferences, which you guys have all seen in the past. This is how can you get it on the other screen, or can you guys all see fine?
I think I can get some other screen set up.
Okay. This is how the kind of an outline of how this talk's going to go. We're going to talk about a brief case that happened last fall on thoracic or on our CT rotation. Some of you guys might be aware of it, but thankfully no harm to the patient. We can talk a little bit about the clinical pearls and kind of treatment algorithms, et cetera, and then we'll kind of go through a little case review. What sorts of things can we do to try to minimize the risks of this happening again, and see if there's anything else. No.
So no, I can't figure it out.
Okay, that's fine. So this patient was a 38-year-old male. He was coming in for a left upper lobe wedge resection for basically a pleural-based nodule that had just been found incidentally during a chronic cough workup. Minimal concerns for lung cancer or anything. Just wanted to get pathology and take it out. So average size guy, 80 kilos. He's got some allergies, penicillin and cephalosporin, so he got vancomycin for pre-op antibiotics. And then his past medical history might be a little bit hard to see from there, but he's got a history of anxiety. He's on, I think, 5 of lisinopril for pretty well-controlled hypertension. He uses a PRN albuterol inhaler, uses some Zantac, and then he's got a previous DVT that he was anticoagulated on for 6 months and has been off for a period of time at this point. So overall, pretty healthy. As far as his anesthetic plan went, he didn't get any of the PO thoracic pre-medications, which is something that we could talk about. Didn't play any role in this case, but the thoracic guys would like for us to be giving all of those PO pain medications that are part of the order set. He got 2 imidaz going back to the room, and basically the case proceeded uneventfully. So he had a nice, smooth, hemodynamically stable induction. Double lumen tube went in fine. At the end of the case, the surgeons instilled 20 cc's of local, 0.5% bupivacaine as kind of intercostals and mixed local anesthesia. And then he was extubated after he was reversed with Sagaminix. So Anyone have any thoughts as to what may happen with this case? This is a pretty standard case. It's kind of open at this point.
Intravascular.
Yeah, have something to do with the local.
Yeah, or he gets too much or something.
What was his weight again?
80 kilos.
Oh.
15.
Very, very small. He was a 12. No. So when the patient, I guess the patient was fine through transport to the PACU, but on getting hooked up to the monitor, started having some tonic-clonic activity, mostly on the left side, and then kind of progressed as a typical seizure would. This happened, I think, twice. Over a period of a couple of minutes, he got 2 milligrams of midazolam from the rest in the bag, in the narcotic bag. For kind of at that point undifferentiated seizure activity. And after that, he started kind of clearing and was able to describe pretty common symptoms, metallic taste, ringing in his ears, some numbness around his lips. So at this point, you guys were right. So this is concerned for last, and they sort of treated him appropriately. Neurology was called. They actually came up and saw him relatively quickly. And their note's a little bit interesting in that they put an addendum in that said this was consistent with last. But by the time they had come and seen the patient, he'd already received benzos, so an additional 2 milligrams of midaz and 2 of Ativan. And at that point, he was sort of having these writhing movements in his arms and kind of hyper-excitable. And you can see that with last as well, and that can be one of the sort of early presenting symptoms is kind of this hyper excitability state as you take out some of the inhibitory pathways before seizing. In this case, he's just seized right off the bat, or this hyper excitable state was kind of masked by his emergence. He got intralipid. We'll talk a little bit about whole treatment of last and everything. I think from a treatment standpoint, the patient was treated completely appropriately. Once last was diagnosed within about 5 minutes, got intralipid within another 5 or 10 minutes. It just takes time to get it from pharmacy or from the PACU where this patient got it. And he didn't have any CV toxicity. It was all just kind of CNS toxicity. Other things for him, he did end up having to go to the ICU afterwards. Anytime anyone gets treatment for last, we have to go to the ICU afterwards. He actually got 2 boluses, so after the first bolus, some of his symptoms resolved, but he was still having some of the perioral numbness. Got another bolus, and ultimately that never resolved. Never had any CV toxicity symptoms. And that's about it.
How is his pain control?
So it sounds like not great. I don't know how much the blocks did. We can talk a little bit about that. Well, it was a little bit of a delayed presentation. It wasn't straight into the vein. We can talk about potentially using some markers and things like that, like epi. I don't know in this case if that would have helped, but it's certainly a thought. So what happened here last? We already talked a little bit about that. His paresthesias kind of lasted for 2 to 4 hours, honestly, after the injection. So he was still having them when he got to the CTICU. Dr. Wolf said that. Ended up with an unplanned ICU admission, probably an extra day of stay, multiple lab draws. They were doing serial EKGs for seemingly half an hour for a while after this case. And then obviously in these thoracic surgery patients, we like to limit how much fluids they get. And we'll talk about how much you get with true treatment of last, but he got like 2 liters of intralipid and in addition to all of the fluids and everything he got during the case. So exposure to the intralipid and the attendant risks with that. Just as a quick reminder, and you guys were spot on, it doesn't matter what your dose is. I think that's a totally appropriate question. Did we give too much local? We were under the theoretical toxic dose of bupivacaine, but if the absorption's too quick, it doesn't matter. If you give 2 cc's right into the myocardium, it's not good either. Intercostal blocks have the highest absorption of all of the blocks that we do. And that was, I think, one of the things that played a role in this case. And then obviously kind of breaking down epidurals, then more vascular territories and then less vascular territories from a peripheral nerve block standpoint. In the most recent update to the last guidelines from ASR in 2017, there's a nice executive summary that goes along with them. They actually say that the kind of incidence of LAST is decreasing, and part of that's to do with ultrasound use and better deposition within peripheral nerve blocks and within epidurals, but it's actually increasing in the community as more people start using local. People like dentists and more out of OR anesthesia or procedures. So overall, we're about the same or maybe increased, but from an anesthesia standpoint, it's a decreasing incidence. Generally, we see the CNS sort of signs before any CV signs, but if the blocks are done under general anesthesia, you're not going to see many of the CNS symptoms. This patient kind of had classic CNS symptoms, both from this upper standpoint, but also the excitable state that we talked about. And then the CV symptoms are fairly variable: hypertension, tachycardia, to sinus arrest, ventricular arrhythmias, all kinds of things. Usually we tend to see the hypertension and the tachycardia to start, and then you start seeing the blocks, but that's not necessarily consistent. And then different local anesthetics have variable vasoactive properties. So cocaine is purely vasoconstrictive, but usually the majority of the other local is vasoconstrictive in low dose and vasodilatory in higher doses. So that could play a role a little bit as well. As far as treatment for recognized LAST, we kind of do the standard supporting ABCs. In this case, the patient really didn't need much. It was just on nasal cannula, talking to the patient or talking to the providers. In between these kind of writhing motions, hyperexcitable state, and didn't have any hypotension or bradycardia or anything that needed any treatment from a CV standpoint. From intralipid dosing, it's the 20% lipid emulsion that we use. The usual bolus dose is 1.5 cc's per kilo with a max of 100 cc's. That is based on ideal body weight. I would say the majority of the time people aren't sitting there figuring out what the ideal body weight is. They're just dosing because ultimately you can basically double the bolus. You can give the bolus twice. And then the same thing goes for the infusion. So quarter cc per kilo per minute. So that ends up being a fair amount. For this guy, if we say he's 80 kilos, it's 20 cc's a minute. And if you're going to run that over an hour, that's faster than those pumps will run. So in this case, they just dialed in 999, and that was fine. And you got a second bolus, like I mentioned. From a neurologic standpoint, there's always a preference for benzos rather than using propofol. People used to say propofol in the lipid sink, or would contribute to the lipid sink. The amount of lipids in there is pretty negligible. And also there's concerns for the hemodynamic effects contributing to the local anesthetic toxicity. And then the final thing, if ACLS is indicated, the recommendations are to reduce your epidoses down to 1 mic per kilo instead of the usual 1 milligram, so that the intralipid can actually get into the vasculature and you can clear it out. And then avoiding all the other agents that we will occasionally use, so things like vaso, obviously more local anesthetics, calcium channel blockers, things like that. And then for true CV toxicity from LAST, there is a note to alert either the nearest cardiopulmonary bypass center or your own institution. I think we had someone 2-3 years ago that was cannulated up in the CTIC for LAST. For this case, this is a little chart from Vanderbilt that they're asking us to fill out when we go over these cases. And across the top, you can kind of see the aims for care. So care that's safe, timely, effective, efficient, equitable, and patient-centered. From this standpoint, I didn't fill any of this out because it's kind of a more emergency treatment. It's not as applicable to like a primary care setting or inpatient care setting. But if you go across the top, so safe is avoiding injuries to patients from the care that's intended to help them. From this standpoint, obviously there was a last event. The treatment thereafter I thought was all appropriate. And there was good communication. We followed the algorithms. They had the appropriate consultants involved. And the anesthesia team was at bedside throughout and kind of treating this with some additional help from APS folks as well. From a systems standpoint, the way that our local, and as you guys all know, our local is kind of on rolling shortages, and you never know what you're going to get when the nurses go to get it. But I think currently we are short on epi containing solutions, and the BUPI similarly is also low, but we have BUPI either quarter or 0.5%. It just seems to change depending on what we have. And they basically go up to the pharmacy and they get whatever is available. It's not written into certain preference cards. In this case, it wasn't that the thoracic surgeons had asked for 0.5%. It was just what they were provided. From a practice-based standpoint, we talked a little bit about this. Keeping last high in your differential for any seizure-like activity. I would say also for any hyper-excitable states, but we see a lot of that kind of emergence, delirium. A younger guy like this, I think if you looked at him and seen that he was, tachycardic to the 110s and hypertensive to the 140s, you'd just say, oh, he's having pain, and he was having pain. So with I'd say in the absence of any other neurologic things, this is not something that would scream out to you that this is last. From a timely standpoint, medications came quickly from pharmacy or from the Pyxis and PACU. We should have Intralipid, I think, in pre-op in PACU, and then up on the 4th floor in the OB workroom. I don't know if there's any up on the 5th floor OB workroom where the CRNAs are. But we probably have easy access to it up there as well. And then from an effective standpoint, the whole point of this diagram is just providing services based on scientific knowledge to all those who could benefit. So I thought they used benzos appropriately. Intralipid was all appropriate. When you order the Intralipid, actually in the computer, it will break down the boluses, and there's actually a little order set for you. It's not a full last treatment algorithm, and it doesn't come with any monitoring guidelines or anything like that, but it at least has the appropriate dosing. So if you just type in lipid, it comes up, and if you can't remember the doses or anything, it just comes up. And then from a practice standpoint, there is a very good ASRA app, the last app, that if you use it, and I put it on the last slide here, if you pull it up, if you have a suspected last event, it will basically prompt you for each of those things. You check them off. It will even, it will prompt you for benzos if they're seizing. You'll hit what benzo you gave, and then after the event is done, it actually prints out a list and the time of everything that was done and when it was done. And it just kind of works you through the whole thing. So I think that's something that could be helpful as well. Obviously, CT surgery wasn't alerted because this patient didn't have any hemodynamic concerns. And then this is another way of looking at sort of events that may have led to this last event. So from a patient factor standpoint, he really didn't have any relevant or known comorbidities as far as major hepatic disease, CNS history wasn't on, and it didn't have lidocaine patches on, anything like that. One of his EKGs had a 1st-degree block, but didn't have any CV toxicity, so not particularly relevant. From a supply standpoint, we talked a little bit about the ever-changing local that we have, but there weren't any known equipment issues while they were depositing the local. May have been some technique concerns. It wasn't one of the fellows closing, it was a resident. Sometimes these cases get kind of rushed along and everyone's trying to close and get out of there quickly, but I don't know how much, obviously it may have played some role, but I'm not sure how much it did. We, from a local concentration standpoint, they will sometimes say, oh, we want a denser block, but if you're really having to give more than 0.25%, all you're really getting is a motor block on top of that. So, if you can't get adequate analgesia with 0.25%, maybe there's something else going on. And the other thing for this is we use 20 cc's of 0.5% over just 3 levels. So usually they'll take that and they'll spread it over multiple levels. This was a robotic case and they were just covering a couple port sites, so they only covered 3 levels. Majority of these other things are sort of self-explanatory. Rushing at the end of the case, I didn't really have any concerns that there were major team factors or organizational things other than potential time pressure to turn over that room and keep moving. That may have contributed to the last event. As far as other things we can do to try to reduce the risk of this happening again, I think the majority of these things were actually followed in this case, but sometimes they're not always followed. So doing a timeout at the beginning of the case, what if we'd been running lidocaine during the case as an infusion, and then at the end they just decided that they wanted to do bupivacaine. It's nice that everyone's on the same page, so talking about that on the timeout at the beginning of the case, confirming the dose before they give it or before it gets added onto the field so that not too much volume is added or that it's not an other medication. And then we talked a little bit about this already. I'm not sure if epi would have helped in this case. It's not clear to me that this was clearly intravascular. Initially, it may have been from rapid absorption. Or it may not have been, and that he had kind of this chronic, or he was able to tolerate one level that was intravascular. So may or may not have been helpful. Consider using that lower concentration, 0.25% instead of 0.5%. We have had, Dr. Donnelly was saying that we've had 3 last cases in the last year that were all with this 0.5% plane, and that's the only unifying thing that they've had between the different cases. So maybe making a push for more standardized local dosing. And then keeping last high on the differential, we talked a little bit about the last order set. And then there's both the ASRA checklist, which upstairs, at least on the OB floor, I don't know how it is down here, comes with the intralipid so that you make sure that you're going through it appropriately and checking off kind of the other boxes, making sure that you're not doing other parts of the resuscitation incorrectly. I think that is something that would be helpful for future last events. As far as tracking this going forward, this is a very rare event. That previous slide said something on the order of 1 in 25,000 to 1 in like 1,000 roughly, so somewhere in that range, kind of a wide range. So it's not something we see frequently. If we've only had 3 events in the last year, it's not something super common, so it's a little bit hard to track that. It's going to be more sporadic unless you make major systemic changes. And then, if you were to make a change to using 0.25% instead of 0.5%, that's pretty easy to track and something we're doing commonly. Here's that app we talked about. Do any of you guys have this?
Are you
The board box.
Yeah.
crisis one for
It
the labs?
Comes along with, or the PD crisis, yeah, that would be another good one. It comes along with the ASRA Coags app as like a bundle.
You have to pay for each one separately though.
There's a bundle though.
And they charge you for each one separately.
Was there?
Just trying to do it.
Well,
Already have the coax.
Yeah, it's like,
then maybe not. Well, I think when I got it, it
Right.
came as a bundle.
Crisis is free.
All right, so use PD crisis.
you just type in the adult weight, it calculates your drug. Sorry.
That's it. Anyone have any thoughts about the case? I thought it was handled pretty effectively. I think it's something that we commonly, I think in the last 2 weeks I've been on CT, we commonly just have 0.5% instead of 0.25%, and it's just like, kind of go with it, and everyone accepts it, but you could dilute it down, you can do whatever.
So a couple of things that I think are important for people to remember, which is, one is that there's an order set for the lipid in EPIC, so that the nursing staff, they're actually being trained to go into EPIC, put in the order when they suspect LAS, so that it brings up what the doses are, and so that they can be more proactive in knowing exactly what they're going to be giving for boluses and for the infusion.
Sure.
And I think that's true for probably most institutions. So wherever you go, just know what knowledge this nursing staff has and what resources they have to help with that whole process.
Also, I lie to surgeons if they're too lazy to look up how much local they can have. I like significant.
Oh yeah, I usually cut it back.
They always get less.
5%.
You've used 2 cc's.
This is something I've wondered though, like in sitting the thoracic rooms, and they're just like, you know, it's like as they're injecting, they're asking me like, oh, how much of this can I use? And it's like, I don't know, like I don't get why 0.5% is like the go-to. Like it would seem better to. I don't know. Do you know of any literature about like if there's less incidence with 0.25%, or I mean, it just happens so infrequently?
I think it's just the availability that we have.
Yeah, we've got 0.5%.
Yeah.
You should also talk to Dr. Saris. I know he thinks that you should use 0.5% and for a denser block, but I don't know. I've never really asked him why him and I think we were chatting about it one day. I know he prefers that, but I think he might be one of the.
Like if Sarah's had his way, he'd run 0.5% pumps for the epidurals.
Yeah.
Like it was just like.
I mean,
Just run
just
phenylephrine, just,
I wanna-
you know.
Next time
Put
you
him on
have a
an
case of
empty
this,
drip
Miguel,
and
just
put it on.
ask him that question.
Yeah, he's on like 3 of VO. Epidural. Yeah, I don't think you feel anything.
John was telling me that
Do you want like
Yeah, maybe that'll be easiest. I don't know.
Oh, no, what?
That's what
hopefully, yeah.
Laura was talking about. Some people he knew at the hospital for special surgery.
They're not working.
And
Oh, maybe it's
the
up
girls, they
here.
run there. So like, yeah, when they run there,
Maybe it's upside down. Maybe that's
down so much that people get like bloodless. They're doing their like.
So that's a plus.
Yeah. Right?
We should just make 0.5% an APS drug or anesthesia.
Where is it?
You're
Oh,
talking
there it
about
is.
intercostal blocks or like when surgery is doing like other port sites or whatever.
Yeah.
I just feel like it's like as soon as they start closing, I'm just like, how much liquid are you using? What are you using?
Yeah,
Can I
trying to be
talk
a
about why he only had CNS symptoms and no? Right, because he was in reverse for the whole thing.
I think it seems like they got. It seems like you got really
more
lucky.
cardiotoxic and neurotoxic. We're concerned.
But the person that had to get cannulated got ropey in their AC.
Okay.
So what is that for?
Yeah.
All right, we'll go ahead and get started.
But they feel like so if it goes in.
Hey guys. My case is a thoracic case as well. This is the same stuff that we had at the beginning. And this is also the same stuff. So we have it organized very similarly for your convenience. So my case is a 41-year-old male. He has a past medical history of cocci. And he had presented with right pneumothorax and worsening right-sided empyema. He had pre-existing cystic lung disease lesions that were known and were being followed. So he was presenting for right vas decortication. I just wrote some remarkable history here. I mentioned the cavitary lesions. He had poorly controlled diabetes. He had this right artery embolization 9 months prior, and then he was on 2 liters of nasopatnol with a chest tube in place. Actually, this is probably just more interesting than reading it over. But here you can see some of the cystic lesions, which were similar in appearance to prior CTs on this empyema. Our plan was to do a general endotracheal anesthesia. We were going to do 2 peripheral IVs. We didn't think an arterial line was necessary. We were going to do ciprofol, fentanyl, lidocaine, and rocuronium. And then instead of using a double lumen tube, this is over at Denver Health, so pretty standard over at Denver Health is we use a bronchial blocker. And then nothing particularly special about the maintenance. So this is our case. There's really nothing that I'm going to point out here. It was, everything went just fine. And then this is our intubation note. And so you can see we use the 9.0 endotracheal tube. And then we placed the bronchial blocker, confirmed with fiber optic afterwards, but nothing unremarkable here. And then here I'll point out this quick note at the end. So what had happened was when we filled up the bronchial blocker, it was filled up with saline. This was probably like a couple months into my into starting, and so I was like, oh, that's fine. I didn't know that's what you're not supposed to do, but it turns out you're not supposed to do that. Well, actually, you're not supposed to. It just it doesn't actually recommend anything other than just air. It just says fill it up with air. But anyway, so at the end, the easy blocker was not easily removed. Both balloons apparently fully deflated. Decision was made to leave the blocker in place until extubation. Sudden loss of end-tidal CO2 and desaturation to approximately 20%. Patient was extubated and mass ventilated with reappearance of capnograph and increase in oxygen saturation. The easy blocker was found to still have 1 milliliter of saline in the yellow cuff and now totally obstructing end of ventricular tube in Murphy's eye. And then after that, it was uneventful. Patient recovered just normally and went to PACU just fine. I had handed off the case probably 2/3 of the way through. So I wasn't here for this portion of the case. But my attending told me about it the next day. And I think that we'll go over some photos. We did take some they took some photos. But you can see that the cuffs are fully deflated. It doesn't actually look like you could have gotten anything more out of them. But as you can see here, that was completely obstructing the entire intertracheal tube, which is a problem. And so in terms of questions that we had, was filling the cuff with saline against manufacturer recommendations? And then was there a defect in the bronchial blocker? I mean, who knows what happened ultimately? I don't think there's any way of saying whether filling it with saline was what caused it or if there's actually a defect in the bronchial blocker itself. And then just some clinical pearls that I had for the case. Just easily being able to recognize signs of airway obstruction. And so that includes, in different situations, potentially reduced tidal volumes, increased peak pressures, either absent versus unilateral breath sounds, depending on where the obstruction is, and then reduced end-tidal CO2, and then capnographic changes that could be different depending on, again, where your obstruction is. So either sudden loss versus a slow decline versus a delayed upstroke. And then late signs would include hypoxia and hemodynamic changes. Hopefully you recognize it before that happens. And then I filled out this Vanderbilt matrix. This top line, I just put no for a lot of things. And this one I didn't have anything. But I think there were a couple issues here. So I did go back and look at the manufacturer instructions. I mean, it's a really, really, really long document. But I read through a lot of it. And it says to fill the cuff with air. It doesn't say anything about should not be filled with other things. But I think that was one thing that was lacking in this case, just knowledge of what you're supposed to fill it with. And then in terms of communication or interpersonal skills, that wasn't something that was handed off when I was handing off the case. I just didn't really think it was particularly remarkable. But I think in this situation, looking back, anything that is different or abnormal about a case should be handed off. And then I don't know if this was done or not, but I think that in either situation, if you're having issues pulling out the bronchial blocker, it should be communicated with the surgeons. And I'm not sure if that was communicated or not, but just as soon as you're having issues, just communicate with them and just say, we're going to make the decision to leave it until the end of the case, but just they're aware that something is going on. And here, again, I'm not sure at what point they realized that there was a malfunction in the cuff, because I don't think it was very high on their suspicion. But if you're having issues getting it out, maybe just throwing a fiber optic down and just seeing what issues you're having or that you're running into getting that bronchial blocker out. In terms of other communication, I think my attending had good closed-loop communication and just let me know exactly what happened the next day. And then what else? Here, I already mentioned this, but they could have potentially used a fiber optic initially before they recognized the signs of hypoxia. And then here, there's no real guidelines as to whether the surgeons want double-lumen tubes or bronchial blockers. I mean, maybe we could think of some sort of guidelines, but largely it's just up to them based on their experience. And then some things here that I said we may be able to do in terms of of improving. Consider guidelines for use for double lumentous versus bronchial blockers. Potentially we can do sim sessions on like cannot miss emergency situations like airway obstruction. And then just being able to recognize the airway obstruction very quickly and knowing your manufacturer guidelines. And most of these I have already gone over, but just to reiterate. And then how could we measure this going forward? We could potentially test our knowledge on proper use of bronchial blockers and then following the quality reports. So this is, something that would be reported in those quality reports that we could do for the cases. But I don't know, I've never heard of anything like this happening before. So, any thoughts?
There was also a discussion at the end of this case. They were attempting to pull the easy blocker when the patient was lateral. So they unfortunately also lost the airway in the lateral position. So that was less than desirable.
So what happened? They were pulling on the bronchial.
Yeah, so
Were you there when this happened?
It got stuck. So it was immediately obvious that there was obstruction because
I didn't know that you were there.
I don't know who's seen the easy blocker, but it's basically just like this long little teeny tube, and it splits into two at the end. So you put it down the ET tube, and then ideally those two ends split right at the carina, and then you just look and you go, okay, the blue's on the right, yellow's on the left, inflate the blue, or whichever side. So they went to pull, and obviously the saline balloon got stuck in the endotracheal tube, so they couldn't get it out. So it was immediately apparent that something was wrong, and that's why the patient was then hypoxic. But the problem is the patient was still on the sides, and the question is, should you wait to pull those until the patient is supine? So if you do have an issue, at least they're in a better position for it.
They're not able to just re-advance it back to get it.
No, I mean if it's stuck in the Murphy bed that
It was
way.
stuck, so, yeah.
It was pretty.
Why
It
did
looked
they
pretty
choose
stuck.
to use saline?
I don't know. I honestly don't know.
Why?
I think he gave some reason, but honestly, I just can't.
Not arrested.
I just can't remember at this point. I mean, I don't remember the reasoning.
But it is tempting because then you go back to too long ventilation. You got this big floppy easy blocker in there, and it's well, why not just take it out? But maybe don't.
That is true though. Every time I did one of those, we took it out lateral. So
Yeah.
it's
Yeah.
that's a good point.
Yeah.
Partially just to get things out of the way so that when you flip, you can just exit it real quickly.
I think about it every time I open it.
So wait, were you in? Because
I was
not
there.
hear about you.
I wasn't in that specific case, but I was there, and then I had a different obstructive case from Children's that got presented along with. Yeah.
Okay. Huh. Interesting.
I wonder, do you think there's any chance were the pilot balloons deflated fully before they tried to pull it?
Yeah.
Oh yeah.
Yeah,
Here,
she
I'll
showed
show
it.
you.
But that was
Because
before.
this was
Completely.
before. This is beforehand. Yeah. So they apparently they were pulling.
Oh, I see how stuck.
And
Because
then
that makes it seem like maybe either there was some obstruction in the track between the pilot balloon.
Yeah, that's-
and
and-
if they
Well, has anybody ever actually injected water saline into these cuffs before?
No, Mike never told
Anybody?
me. The only ones that
normal
you put saline in are
So
the
ENT
laser
cases,
tubes.
Yeah,
you
I've done
often
it
will
for
do
the-
that for
yeah.
ENT cases. So
But I
Typically-
thought that was for the
laser
laser
tube, but not
tubes,
the
not the
bronchial.
block.
no, I
Right.
agree, but the pilot balloon is similar in the way it responds.
Okay.
So what do you remember about when you inject your
It fills up, but your
fluid?
balloon doesn't feel that.
That's
Yeah.
right. And when you suck it out, does
Same
that
thing.
Same thing.
Yeah.
Oh, so you gotta.
So
how
it
do you know?
looks deflated the entire time. So the key is knowing how much volume did I put in there in the first place.
Mhm.
So if you ever put volume into it and you're not finishing the case, that's an important piece of information to sign out, to say I put 4 cc's into this cuff.
Mhm.
Because it doesn't look like it has anything in it.
I've never done one.
I haven't done it for laser. I've done it for because you add it for diffusing out basically to make it for less coughing afterwards.
Like Lidocaine.
Yeah, that's what you put in there.
What?
Yeah, it was nice. It worked well.
It's only nice if it's
It's
take it out.
it's just that one area and it doesn't move at all.
Anyway, so don't do that.
So I guess one question I have for residents, you're in that lateral position, you're not moving air, that bronchial blocker is not coming in or out. Does everybody feel comfortable pulling out that tube at that point?
I think if that's your highest suspicion.
If you're thinking that it's your tubes that's clogged, you get that.
Yeah.
That's a hard decision to make, right?
Yeah.
So you have to be thinking about that. Getting down to the 20s for a saturation probably is too late, right? I mean, you need to be making a decision before that. That you need to have some intervention.
Well, I think that those lateral thoracic patients are like impossible to turn. I mean, like everything is taped down, so you can't just be like, we need to get supine now. I mean, that's
They're like
not gonna
mummified.
happen.
I think thankfully at that point they didn't have to re-instrument the airway at all. They just masked, and then the case was close enough to finishing that they just woke the patient up. So
Potentially you could also drop, like, cause I've had one case, I think it was like my 4th week of CA 1 year where I lost my end title, and then I called Wilkie in a panic, and that went really well. It was really calm. It was really, but you just plugged like the end of her tube. And we were in prone also, that was also part of the issue.
Oh.
But like, if I was in this situation, I probably would drop a suction catheter first as like, just my like own bias from like that.
But I think
Would
if
you do it
the
if you had
easy
a
blocker's not
blocker
coming
in?
out, like.
Well, yeah, I mean, but also, I mean, the patient had like pretty nasty like lung disease, so I wouldn't be like surprised if they were like, their air was pretty gross.
I had one of those at Children's, and it was the whole end of the tube. We had to extubate, re-intubate in the middle of the case.
I mean, I think one of the things is like, when you're manipulating something and something goes wrong at that point, it probably has to do with something you do it.
Yeah.
And I ran into a case at Children's with one of those laser tubes with the 2 balloons. The first balloon goes up, and when the second balloon went up, it pushed the tip of that tracheal tube straight into the wall of the trachea. Now you couldn't ventilate.
Oh.
And so it was like, and as soon as you deflated that cuff, things were fine. But you don't think about simple things messing with the mechanics. Undo what you just did.
put it back in.
That's a great case. Why don't you guys take a 5-minute break, and I'll see where our next lady is.
He's the only one who does. He's the only one who does thoracic. Oh, over there. We don't even have to.
Karachi does everything.
Karachi's the man. Hitting high notes. We have a little stir. Oh, really? Yeah.
They're going to split
Recruitment going on. There was a little bit of a lull. Right? It's cut on the bottom
Because it's wider.
I'm gonna go through. Not easily. That's for these instead.
Oh yeah, should we get it?
I just have one question right now. That was supposed to be your short day.
Oh, they took the whiteboards out of most out of the conference room.
Yes, they are high tech, right?
Yeah, but sometimes, I guess I'm low tech.
That's why you're texting.
Oh.
Then you can't like hold residents for like,
Yeah, that's true.
to like cover that, you know? Yeah, I think that. Everyone.
I think they might be right. That's fine.
Great.
No, I'll get my glasses.
So I'm gonna try to moderate things a little bit too.
Okay.
Make sure that
So,
we've got different levels of PGY. We've got 2s, 3s, and 4s predominantly. So some people are graduating this year.
Okay.
Moving on.
Okay.
Others.
so yeah, why don't we do this and you can maybe put their completion date. Just so
So completion date.
yeah, that'll give me an idea.
One lane road, Rex here.
2020, hard to believe.
Right? So we've got a sign-in sheet passed around so that she can contact you down the road when you're getting ready to graduate. For those of you who are CA3s, contact you again later on.
Or already has an epidural with 2 alcohol use over Yeah.
Thanks for doing that.
Oh, yeah.
Or they gave the lady some 2 days ago.
Just each lane on their side of the whole. Now
Yeah, she was thinking about she was on earlier tonight. She would be with like an license. Like I think it's a question.
to drive our here. So the guys actually walk our
We've all been
And she just like
and we're establishing like
then yeah, she was about to
There you go.
well, right. 10 days. That's more it. We bought each. We're the same. We're the same here at Potter House.
It's like, wait.
Time to get my I can do a few This sounds good. Oh yeah, actually.
Yeah, I remember meeting the guy who Oh yeah, basically, yeah.
I didn't know you are. My wife was
Something going down there.
Box.
All right, we're going to go ahead and get started. So this is Lynn Johnson. Like I said earlier, she works for Standard still, yes? Or did it change?
No,
Still Standard. I've known her for about going on 10 years, close to. And I think that she does a really good job of being very in-depth about what it means to have disability insurance, what are some things to consider when you get your policy. There's a whole host of complexities that can be played into your policy depending on riders, which are additions to your policy. And there's lots of options depending on the company you go with. So she'll talk through some of that, I'm sure.
I will.
Yeah.
Yes, thank you very much. How many in here are finishing this year? Okay, so, all right. And then next year, or a couple of years, 2 or more years to go. Okay, all right. So this packet will be yours to keep. There's a lot of info in here. And my contact information is here. I actually live in California, and I've been working with this program since 2005. There's a little resume card in here that tells you a little bit about my background. If I help you with something, I will continue to stay in touch as time goes on. Just ask that when you move around that you let me know so that I can be effective at doing that. Also, just a little bit more about myself. Just so you know, I'm not an employee of the university or any insurance company or the university, any carrier or GME. But I've been authorized by GME to bring this benefit to the awareness of the residents so you can take advantage of it. There are some things, I know you're getting inundated with emails almost on a daily basis from all kinds of folks around the country. This will be a little bit different than there are a couple of features here that you won't be able to get outside of the GME program. And that being said, just so you know, I do work with a variety of carriers, so if looking around the marketplace is something you want to do, I can certainly help you do that so that you feel like you've made the most informed decision. Have any of you already ever applied for disability insurance? Anybody have it? Okay. All right. Is it already in force? Okay. All right. So you know it's a bit of a process to go through that. Under normal circumstances, when you go out in the market to get coverage, it's not that easy to acquire because the insurance companies are going to be looking at you very closely. And it doesn't take much to have a blip in the radar. For example, taking something like Zoloft could be grounds for a decline. Having an injury to a shoulder or knee often puts an exclusion on that body part. A history of migraine headaches is problematic. A female who's had a C-section has all future pregnancies excluded because that's considered a complication. So the point I'm making is you don't have to be disabled to have an insurability issue. And we're going to spend most of the time talking about points on this page here. So the first one on there says that it's available on what's called a guaranteed issue basis. And that's really huge because what that means is you don't have to go through the normal protocol. There are no labs, no health questions, no activity questions. So if you're a rock climber, that's something that normally would be excluded. None of that is omitted on this benefit. Everyone, as long as you have not applied and been denied or postponed in the last 7 years, you are able to do this because you are part of the GME program. Probably the most important benefit provision on any policy is the definition of disability, because that's going to determine how you would be paid in the event of a claim, or even if you would be paid. So this comes with something called own occupation and specialty specific. So that means that the definition is going to recognize your board specialty of anesthesia as your medical that's your medical specialty, that will be your occupation. So if something should happen, you get sick or injured, and you can't practice anesthesia, but you could do something else, even if it were related to medicine, you could earn the outside income and still collect on the policy. Some plans are own occupation, but don't have the specialty language. So why would that be important? Let's say that you don't have the specialty language. You're working as an anesthesiologist. You do a lot of procedures. Something happens with your hands. You can't do that. So now you are able to do maybe wellness, like workers' comp exams or family medicine kinds of things. Without the specialty language, your occupation is that of a physician, not an anesthesiologist. So that's a really important thing to be aware of. Any questions so far on anything? Okay, now.
Well, one question I want to throw out there is, why do you need disability insurance when you're all done? So you've got a policy. Why'd you get those policies?
Just to ensure that let's say you can't continue on forward as doing the line of work that you planned out to be, that you get some compensation for going through all the training, the debt, whatever you have to cover at least some living costs and other things.
Yeah, how about you, Dave?
I have a family and we have certain expenses that we need to pay for, no matter if I'm working or not.
Exactly.
Yeah, so that's really the big thing is you have to have thoughts of 5, 10, 15 years down the road when you finish what your life might look like and who might be relying on your income and what income level do you need to provide, right? That's a really important piece as we'll start talking a little bit about what your benefit's going to be. How do you decide what benefit to purchase, right?
Yeah, and those are really great points. Your greatest asset is really your ability to earn an income, and you're all putting in a huge amount of time and money to be able to get to the point that you're going to generate the kind of income that you'll have, and it's so important to protect that because it can change. I mean, you see it every day. It can change in a blink. Now, for those that are in their final year, and this would for those of you that already have coverage, I don't know how much you had, maybe $5,000 a month, probably, since that's pretty a typical amount while you are in training. This year, for the first time, since this program was made available, the limit has been increased. And everybody can start with as much as a $7,500 a month benefit. You can also have $5,000, and third choice is $2,500. In the event that you were to become disabled and you were collecting that benefit, you're going to collect it on a tax-free basis. The IRS has no claim to that. And why is that? Because when you pay for a benefit like this, you're sending the premium to the insurance company with money you've already paid tax on. It's your take-home pay. So at claim time, you get to keep it all. So you get a check for that full amount. Nothing is reportable. Okay.
Can you talk about the flip side when the employer is providing a portion of your
Yes. Let's talk about that. So, do those that are finishing, do you know yet where you're going to be working? Academics, private practice? Academics?
Private practice.
Okay, so a little bit of both. All right. So when you take a new position, you're going to get a whole array of benefits, probably a 401k, life insurance, health insurance, and it's going to be pretty common for you to also have disability insurance through your new employer. So when an employer provides disability coverage for you, depends on the employer, but there's usually a formula that they go by, and it's common to see this, 60% of your income to some monthly maximum. I'm going to trip over that. It's common to see $10,000 a month. So let's say that was the formula you had, and you were making $100,000 a year, and you went out on a claim. So 60% of 100 would be $60,000 or $5,000 a month. If you were making $300,000, 60% of that is 15. But in this example, it maxed out at 10. So it's just going to depend on your employer and what they have. When the employer is providing this for you and you have a claim, you don't get to keep it all. It's going to be taxable. So it's going to shrink by your tax bracket. So you're not really getting 60% of your income. It's more like 40 to 42% when they get everything taken out of that. It may turn out that position that you take right after you finish your training is where you stay for the next 20 or 30 years. But as young as all of you are, it's reasonable to think you might have more than one employer over the course of time. So if you leave that employer, you don't take the benefit with you. Sorry, I'm not writing very well in here. It's not portable. When you have an individual policy, it is portable. Your only requirement with an individual plan is to pay the premium. Even if you're not working and you become disabled, with an individual policy, you're still covered. That won't happen here, because if you're not working, everything would be over. So that's another reason to consider having your own individual plan. The language in a group plan tends to be more restrictive. It's not as comprehensive as an individual policy. For example, if you were on the faculty here, your occupation is protected for 2 years. So if you were working as an anesthesiologist and you became disabled and you go out on a claim, you get sick, 2 years later, you're still out, you're not able to come back. But during that 2 years, you were able to figure out another way to make some money. They're going to take that income that you're making after that first 2 years and apply it against your group benefit. So your group benefit's going to be reduced by whatever it is you're making. That won't happen with an individual policy that has the specialty language all the way out to 67. Now, the good news is that you don't have to try to decide, well, should I just count on my employer or should I just do this? You're in a window. When you're in your final year, you're in a window that you probably won't ever be in again, where we don't have to follow the rules. There are no health questions, no financial questions. Everyone can get $7,500 and possibly more depending on your circumstance. So the individual plan and the group plan are added together. And in the event of a disability, you collect on both. The group plan can't look at that and say, oh, we found out you have an individual policy, so we're not going to pay. They both have to pay. Okay. One of the key things I haven't written down here, there's a term, a provision that this comes with, and the word is non-cancelable. And what that means is that once you have an individual benefit, your rates are locked in at the age you start all the way out to 67. The only way that it could be taken away is if you fail to pay the premium. As long as you pay for it, everything is locked in until 67. If you were permanently disabled, you collect the benefit until you're 67. So the point is the policy lasts until 67, either because you choose to keep it until then or because you're on a claim and you're receiving the benefit. Questions on anything so far?
Question.
Yeah.
How do they decide what amount you're getting a month? The $2,500, $5,000, or $7,500? Is that like your degree of disability, or?
No, that's what you get to pick.
Okay.
That's the offer that this benefit provides. You get to pick. Now, let's say that you don't do any of this and you graduate and it's a year later and you call me up and you want to know how much can I get. Now we have to follow the rules. So I'd have to know what your income was, what your group benefit would be. There would be charts that I would look at, and I would then tell you how much you would be able to get. Depending, let me give you, since you brought up a really good point here, you're all going to be very high income earners once you are completely finished. Most people want to get as much as they can because the younger you are, the lower the rate, and then it's locked in. Let's say, for example, kind of jumping ahead, but I want to answer her question. Let's say that you got your first job and your starting salary is probably higher than this, but let's say it's $200,000 and you're going to take, you call me up and want to know how much disability insurance you could have making that income. I know, because I've done this a time or two, that you would be able to have $9,400 a month of individual coverage. So that would be the amount of individual benefit you could get. One of my first questions is, where are you working? And let's say you're working at Denver Health. So I know what their group benefit is. It's 60% up to $15,000 a month. So I can't look at the same chart that I would look at if you didn't have any group benefit. I would look at a chart that takes that into account. So in that scenario, 60% of 200 would be $10,000 a month. You're going to get $10,000 from your group benefit. That's going to be taxed. And then the chart says in that scenario, $200,000 with the group benefit, you could have individual coverage of just under $4,100 a month. If you had taken advantage of one of these two options and you had that same scenario, you're way ahead of the curve. And so that's why you might want to, when you're in your last year and we talk about it in more detail, that is a reason for getting this, because it might be difficult for you to get up to that $7,500. Let me give you another example. Let's say, come back to taking a position here. The group benefit here is 60% of base salary up to a monthly max of a little over $23,000 a month. So if you started off working here and your entire base salary, let's say it was $350, and you started with $5,000, you couldn't have any more. because the guidelines don't support that. So that's another reason. If you'd started with 7,500, you technically in that scenario are a little overinsured, but the carriers know that you're going to be making a lot more income. Your income is going to continue to grow as time goes on. Does that make sense?
So that last point she made, I think, is a really important point, which is when you are practicing, you have to know whether your salary is inclusive of all of your call and all the other things that you are doing, or if the structure that we have at UCH, for instance, where there's a lot of incentive components. So call is incentivized, we have quarterly bonuses. Those things don't go into the calculation of what your base pay is. So if you're expecting your salary to be at a certain level, but your base pay is something lower, then you have to ensure that you're covered from a disability insurance standpoint to rise up to what your incentive component might have been. Right?
Yeah, that's a really good point. Yeah.
For example, are the group coverages here and then member health built in? I mean, are they something you pay an extra premium for?
No, you don't. If you take a position here, you're going to have to be here for 1 year before you can get the long-term benefit. They pay for the long-term here. You pay for the short-term. You should definitely sign up for that. It's minimal. It's like $7.
It shows up as a line item on your pay stubs.
It's worth having because the group plan here has a 6-month waiting period. That's pretty long. Denver Health, you're covered right away once you start that position, and it covers your earnings. So it doesn't break it down like just base. It covers everything that you have.
So a lot of people carry both individually and group then.
I'm sorry.
The recommendation is to carry individually.
Yeah, really most physicians have their own individual plan because, and especially if people take the time to, like we're doing, go through this and understand it, it makes sense to do that because I've had, usually every week I get 1 or 2 emails, oh, my employer's giving me benefits, so I don't know if I want to do this. And I understand that, but it's kind of almost naive to think that an employer benefit is going to take care of you. There's nothing that says the employer has to provide it. They might decide, you know what, we have to pay for health insurance and it's getting really costly, so we have to trim some things. And so it's not a guarantee that you would have that. So yeah, those are good questions.
Did USAP offer that?
They do.
Do they?
I haven't looked at what the actual formula is though. I'll have to look at that one.
Other questions on anything there? While I'm thinking of it, for the two of you that already have something, let's just say that you had, I don't know how much benefit you have, but let's say you had $5,000. You would then be in a position, if you wanted to supplement it with this, to have $2,500 so that as you exit, you have the $7,500 total. And another advantage of doing that, if you are going to be a really high income earner, having more than one carrier is not a bad strategy because they both would have options to increase, and you'd have the potential to get even more coverage as your income goes up. This benefit is going to come with something called a cost of living rider, and that's a benefit that's designed to protect whatever amount you start with from inflation. Especially if something happens to you early in your career, before you've had time to accumulate savings and investments. So the cost of living rider will get activated once you have been disabled for a year. And after you've received 12 payments, then that monthly benefit, whatever amount you have, is going to start to go up. It's going to be tied to the consumer price index, and it's going to go up by a maximum of 3% each year on a compound basis. So let's say that you started this at age 31, and at 33 you're in a car accident and you have some pretty serious injuries, so you go out on a claim. And let's say you took the $7,500, so you're getting that. And before you know it, a year has gone by and you still are not able to return to work. So if the CPI was 3% and you had $7,500, that would add $225 to that $7,500. And now for the next 12-month cycle, you're getting $77.25 a month. And every year that you continue to be out, it will continue to compound. Let's take another example. You still start at 31, but this time no car accidents, everything's good. Now you're 51 and you get sick. If you've never made any changes to the benefit, that you started with, it would still start at 51 at that 7,500, and then 1 year later it would start to adjust. So the cost of living rider has its greatest impact if something happens when you're younger. Okay. Questions on that? All right. There's a discount. By now, you probably may be aware of the fact that women pay a lot more for disability insurance than men do. We're cheaper for life insurance. We still live longer, but we make more claims. And so industry-wide rates for women are significantly higher. So GME has negotiated some discounts on your behalf. There's something called a unisex rate with an additional 15% off of that. So the guys are not subsidizing the women. The guys are getting a break. The women are getting a huge break. And that discount stays with you. It's locked in all the way to 67. If you later increase your coverage, that increase will reflect the GME discount as well. Okay, that brings up something called residual disability, and residual means a partial disability. Something sets you back, but it doesn't take you out completely. So an example of residual would be, say you're out skiing and you have a tumble and you hurt your back. And when it first happens, you think you're okay, you come back to work, you're doing your job, but then that injury...
Are you guys doing a Zoom meeting?
No.
No, okay. But there is a Zoom meeting connected and no content sharing.
Yeah.
Okay, that's fine.
Thank you.
Okay, so the accident. So that back injury continues to be aggravated. It gets worse, starts to wear you down. You reach a point where you say, you know what? I can't keep up the pace. I can't take as much call. I can't do as many cases. I've got to cut back. I could work half time. So in a scenario like that, where you've had a 50% loss of income, you would be able to collect 50% of your disability benefit. And you don't have to be totally disabled first. That's important. I know you get a lot of stuff from the AMA. There are a lot of association plans, the AMA being one of them. It doesn't matter what association plan it is. None of them have this provision. None of them are non-cancelable. So the rates will go up as you age. They'll be very low in the younger ages. The association can change it at any time. And some associations, it only protects your specialty for a limited time, kind of like I was describing the 2-year limitation here. The other big difference is back on that same example I just gave you with the back injury. So if we took that same claim scenario, you have a ski accident, you hurt your back, you're working half-time, you've lost half your income, but this time we're going to change companies and we're going to put you on the AMA plan. And then the question is, how much are they going to pay in that same scenario? And the answer is nothing, because there's a clause in their benefit that says in order to collect on a partial basis, you're going to have to be totally and continuously disabled first. So you might never be totally disabled. You have a degenerative kind of thing or an illness that slows you down. So the point about that, and really all of this, is that contract language is everything. You have too much at stake to not have the best definitions that you can have. Any questions on residual or being partially disabled? Okay. There's a rehab benefit that's designed to give you adaptive devices to help support your return to work. If you ever became HIV positive, if a licensing board or an employer were to ever put a restriction on you and say, sorry, we can't have you working here with that condition, that would give you grounds to file a claim because that restriction is preventing you from doing your specialty. Okay. Now, that brings up something called the benefit increase rider, and this could be significant as time goes on, depending on your employment. The benefit increase rider is the feature that says whichever one you start with here, you're going to have an opportunity moving forward to add on to this so that you have as much as a total of $15,000 a month. In order to have $15,000 a month, your earnings would have to be $350,000 without any benefits from your employer. Okay? The normal sequence of how this rider functions is that when you start the benefit, your first opportunity to make an increase would be 3 years later. So you'll get multiple messages, emails from me, from Standard, which is the carrier. You'll get a letter in the mail reminding you that this window is approaching, and we have to respond. In order to determine if you're going to be able to increase your coverage, it's going to hinge on two things. One is going to be your income, and we know that's going to go up. And the other will be your group benefit, and that's this. So they'll ask those two questions, so we'll answer that, we'll send it in, a calculation will be made, and they might come back and say, yeah, you could add on another couple thousand, so we would do that. Or they might come back and say, no, based on your group benefit, there's no room to add on. So the fact that we responded would allow that benefit increase rider to be reset, and it'll come around again 3 years later. What we don't want to do is ignore it. If we just ignore it and say, oh, I'll just catch it next time, there won't be a next time. So we have to be very mindful of that, and that's why you'll get lots of notices so it doesn't fall through the cracks. Now, there are some exceptions to that, having to wait 3 years. And let me give you an idea of what an exception would be. Let's say that you're joining a private practice and your starting salary is going to be $300 and there's no benefits from your employer. Then that means that you actually could have more than $7,500 if you wanted to. And what that's going to be called is a one-step. And that means that in one step, as you finish, you can start off with the most that you're eligible for. And why would you want to do that? Like Tony was explaining, if part of your salary is not protected by a group plan, you have more income to protect, so you're at greater risk for that. And as I said earlier, it's based on your age. So if you could do it sooner rather than later, it would be less costly, and then you lock that in all the way out to 67. Okay. Questions on that benefit increase rider?
So in my view, that's the most important rider for income purposes. So for my situation, being here where you have a lot of incentives as a part of your salary, I can use my salary for this income part and not be looking at just my base pay. So I was able to flex up then my disability based on this rider to cover that incentive portion that the employer would never cover, right? So that's something to consider when you have your employer covering part of it.
Yeah, that's a really great point. Thanks for bringing that up. The next two benefits are optional. And the first one is the catastrophic rider. And that's one that says if you were to have a disability that's just that, catastrophic in nature, where you had a severe cognitive impairment, or you were unable to do 2 out of 6 activities of daily living without assistance, such as bathing, dressing, feeding, you could have the policy pay an additional $5,000 or $10,000 a month on top of whatever you start with. The rationale with that rider is that although a catastrophic claim is not as likely to occur as some other type of disability, if it did happen, you're going to have a much greater need for more cash for care. So for a relatively low outlay, you've generated a lot more dollars coming in. You might decide, that's nice, but I don't want it. And so you don't have to include it. If you don't include it initially, on the initial offer, you cannot add it later. If you start with it and you later want to reduce it or take it off, we can always do that, but we can't go the other direction. Does anybody have any student loan debt? Okay. So this is a relatively new feature within the last couple of years, the student loan rider. And it's a benefit that would allow you to have as much as an additional $2,500 a month. That's on top of your base benefit, in addition to the catastrophic rider, for a 10 or 15-year period if you were totally disabled, to give you more money to pay that student loan obligation. Student loans are forgiven in the event of a death, but not a disability. So let's say that you decided to take that benefit for $2,500. You started at age 31 and you took it for 10 years. And at age 42, you became disabled. That student loan rider would have expired because the 10 years is up. So the 10 or 15 years starts when the policy starts. Let's say that, let me give you another example. Let's say you decided you liked that benefit and you were going to have it for 15 years, and in 8 years you have your loans all paid off. Then we would just notify the carrier and say, loans are paid off, take that rider off, and then your overall premium would go down because you don't be paying for something that you can't use. There is something called a waiting period or an elimination period. It's the amount of time that has to pass from the onset of an illness or an injury before you can start to receive the benefit. That's going to be 90 days. That's pretty typical with an individual policy. If you're on the faculty here, it's 180 days for the long-term benefit, and it's 90 at Denver Health, if anybody was going there. That's a lot to listen to. Questions? About anything in particular? There's one other point I want to mention. It's down at the very bottom with little asterisks that says 3/12. What does that mean? You can choose when you want this to start. So if you're in your final year, if you were graduating in June, the soonest that you could do this would be February 1st. The latest that you could do it would be September 1st. After that, 60 days after you graduate, the window closes on it. So most people will have a July 1st date because your GME benefit ends at midnight on June 30th. So let's say you had a July 1 date. This 3/12 means that anything that you've had any medical treatment for or sought treatment for or taken any medication for in the 3 months prior to that effective date. So in that example, April, May, or June, you would have to have the policy for 12 months before you could file a claim for that condition. So nothing is excluded, but it's a bit of a deterrent to keep someone who knows they have some major problems from signing up and then immediately turning around and filing a claim. All right, now let me give you some numbers here. See if this works. Oh, that's good. Okay. Sometimes the erasers are not very good. All right, can you, does anybody have any what ifs or anything in particular that you want to ask? No? All right, so I'm going to give you a couple different, you know what, I want to talk to you about one other thing. A couple more things. You have a be careful statement in here. I know you're getting inundated with messages from all kinds of folks. And you might look at something and they might say, oh yeah, that's, maybe it would be lower than this. And so you decide, the financial advisor says, well, we can just apply and we'll see how it goes. We're not quite sure, but we'll see how it goes. So let's say that you go ahead and do that and you have a blood test and you have some elevated liver enzymes. Insurance companies don't like to see that because they don't know what that means. So the carrier could come back and say, you know what, we're not sure about that, so we're going to hold off. You can come back and talk to us in a couple years. So if that were to happen to you, anytime within 7 years of talking to me about doing this, that just nixed your ability to take advantage of this. So we want to be very careful. If you want to look around and check out other things, I will help you do that so you can evaluate for your circumstance what is going to be best. But I just want you to be careful. The other thing, for those of you that are a ways away, does anybody have like 2 or more years to go? Okay, so this is also something new that wasn't around when you went through the program. It's called the IN program. So if somebody wants to have coverage while they're in training, but doesn't really want to commit to going through the underwriting process or having such a large amount being on a resident salary, you can do a smaller benefit. You can have $1,500 a month of coverage. And it would have everything on this page up to, but not including those last 3 points. So specialty specific, the rate is locked in, the cost of living rider, the residual benefit. And then when you're in your final year, you have the guarantee that you can get the rest of this benefit so that you could have as much as $7,500. This program is evaluated every year, and there's not a guarantee that it will always be here. So if you have a ways to go, having that in program is kind of a good idea because you've just secured your spot to do this, just as though, like for whatever reason, let's say it was taken away, and you got it 2 or 3 years before that, you could go ahead and do all the things that I'm talking about just as though it were still in place. Okay. All right. So let's talk about some numbers for those that are finishing sooner. Give me an age, if you would, please. Anybody tell me how old
33.
they are? 33. Okay. All right. All right. So, and does anybody have a May or June birthday? No. Okay. All right. So if you were to do the $7,500 a month benefit at 33, your monthly premium would be $355.80. That's without the catastrophic and student loan riders. If you wanted to load it up with everything you possibly could, so you did $7,500, you took a $10,000 catastrophic rider, you did the student loan rider for $2,500 for 15 years, then the highest it would be is $423.74. Okay, and if you pick some other combination, like let's say you didn't want the student loan rider, and you didn't want the catastrophic rider for 10, but maybe for 5, then the monthly premium would be $373. So that's the low, that's the high, and depending on how you design it, it will land somewhere in between. Now, at age 33, if you did the $5,000 a month benefit, it's $237.21. And if you put everything on it, this is actually for a student loan rider for $2,000, so it would be a couple dollars more than this, but it's $298.63. So that gives you an idea between, and this is for 5,000. Okay. Other ages? 30. Okay. All right. So at age 30, it'll be a little bit lower. So it's $324.01, and if you put everything on it, it would be $384.37. And if you did the 5,000 instead of the 7,500 at 30, it's $216.01 and $270.87. Okay. Any other ages that you want to see? No?
That's probably ballpark for everyone.
Now,
Some of us might be out
some of you
Sorry,
what?
David. I forgot your
I want to talk to you about a carrier that I want to mention this because I know if I don't mention it, somebody, if they haven't already, will. In your specialty, there are some discounts in place with another company. It's Principal. And a lot of folks in your field get those rates, and they look at these numbers and they go, it's quite a bit lower. And that's fine if you I just want to make sure that everyone understands Principal's a great company. For someone who's very procedure driven, you have to understand that the specialty specific language is not in the contract. I know that people are being told that it is. You get these spreadsheets that say it is, but it is not. The language that says your board specialty is your occupation is not in that Principal contract. So I just want you to be aware of that. And understanding that, if it turns out that Principal is the preferred carrier that you want to have, then that's great. But you just have to be informed, be an informed consumer about it. Okay. Any other ages or any other questions? Did you have a question?
Yeah, I guess I had one question. Just knowing that it sounds like the plan is like totally agnostic to medical issues or like the amount of risk you take on as a person. Just from your experience, is it a little bit higher than the market rate, or is it pretty comparable?
It's the only carrier that's going to be lower right now for you would be Principal, and that's why I brought that up. So if we were to look, there's Guardian, there's Emeritus, there's Ohio National, there's Mass Mutual. I work with all of those carriers. We could look at that, but it's not going to be. There's not going to be much of a difference. And in most cases, it would be probably a little bit higher than this. And if they are almost identical, or maybe a carrier is like $10 a month lower, unless you have just a pristine medical history, you wouldn't want to go through what you have to go through probably to do that, because it just doesn't take much. Yeah.
So is the big downside of not having a specialty specific clause like you guys have? Is that because they would say, well, if you don't have your hands, you can still
They could. See, that's the thing. I've talked to a lot of people. I had a conversation because I run into this, especially in this arena. With anesthesia and orthopedic surgery, because you're in the same occupation class, and they see, people see these lower rates. I had a discussion last summer with the head of claims at Standard, and I asked that very question, and the reply he gave me was really perfect. He said, "It's the contract, not the intent that stands." So on the marketing pieces, and you see that it looks like it's going to cover you. You might have a claim 15 years down the road, and if it was a battle and you were in a court negotiating over that, technically, contractually, that specialty language isn't in there. So it's something that you'll have to kind of weigh on your. If you had any health issues, then this definitely would be the way to go. If everything else was equal and you were you could qualify for the one, and that difference was just so much more preferred that you wanted to do that, you could. I just want to make sure that everybody understands it before, because a lot of people will get in touch with me saying, "Oh yeah, I got it. It's just like that," and yeah, it's not quite like that. Yeah.
Sorry.
Either one.
So these are monthly premiums?
These are monthly.
And does the rate increase with your age, or that's like the
once you get it, you're locked in.
Until age
67.
Yeah.
And down the road, probably not initially when you're first starting off, but if you were to pay once a year rather than once a month, you'd save another 5%. So that makes some difference. What's your question?
I'm just looking at the second page in this packet. So you guys are providing our current group coverage under the GME?
Standard does,
Correct.
Yeah.
And so that's the 3,000, 3,500, 4,000.
Right.
Depending on our PGY year. And
yes.
Basically, this is offering a group to individual conversion at the end of our training.
Yeah, somewhere in your final year. And I know for your academic years go from July through June. For the purpose of this benefit, Standard considers it October of your final year through up until September 1st, 60 days after you.
And when you sign up in that last year, when does the coverage switch over?
You would so let's say you were in your final year right now and you wanted to do this, you could start it now. You could have it as early as February if you wanted. If something happened while you were still in training, you'd have that GME group plan and this. Okay.
What was it you were saying to those of us who are still early about locking in early?
The in program. So If you wanted to have the guarantee that you would always be able to get all the things I've talked about, but you still have a ways to go, you could get the smaller benefit, a $1,500 a month benefit. And for example, I don't know how old are you?
39.
You're 39. Okay. All right. Sorry, I made to put you on the spot. Okay. So if you did at 39, if you did a $1,500 a month benefit, that's $91.51 a month. If you were 32, it's $68.82.
And that's $1,500 on top of the GME.
Yeah. Mm-hmm.
And then which is then guaranteed to convert to the higher.
Yes,
At the end of
at the end, and that last year from October through up to September 1 of that final year, that you could choose to have a total of $2,500, $5,000, or $7,500. Okay.
Thanks.
Yeah, you're welcome. Any other questions or what ifs?
What about travel? Because I see this thing here. So some policies will not cover travel.
Okay, like what kind of travel? Like foreign travel?
Yes.
You're covered wherever you go in the world. So if you got disabled overseas somewhere, you're covered. If you decide to reside in another country, you would have to return to the U.S. after a certain amount of time for the claim. But you are covered. There are some. Like if you were going, like there are a lot of folks that when they're in training, they want to do like a rotation in different parts of Africa or whatever. So if you were getting ready to do that and trying to apply for coverage, they'd say, sorry, we won't cover that. If that was something you were going to do and you had access to this, that is covered. So it doesn't matter where you go. Okay, I really appreciate Tony taking the time and setting this up and everything, and all your questions. And I'll stick around. I don't know if you have to be somewhere, but I'll stick around for a few minutes if anybody has anything like for your situation that you want to ask me. Happy to do that.
Yeah, my last comment is that of the many insurances that you're going to have to worry about when you finish, this is probably the one that is the most important for lots of reasons, and so you want to be very careful about your thought process of what plans you choose, the amount that you think you need to pay your bills. If you have kids, do you need money to help pay for their college? Do you need money, to put away for any other reasons? Like all those considerations have to be taken into account. So it's a really important process. I will say that I had the 5,000 when I finished residency. When that 3-year interval came up to see if I could qualify for more, I was able to bump that up. I believe I bumped it up quite a bit.
We maxed it out.
Yeah, I think I went up to 13,000 total for my monthly benefit. And then that's with the knowledge that that's not going to be taxed, that that's money I get. And then what I get from the hospital then gets taxed on that 60% of what my base is.
Everybody in your packet, you have an actual application. So for those of you that went through the regular process with another carrier, you can take a look at this and see how much different this is. It's your name and address, your basic monthly benefit. That would depend on the amount you have. Really the only questions are they want to know if you've applied any time in the last 7 years and been postponed or declined, if you've had any type of a disability in the last 12 months, if you've been at work full-time for the last 6 months, and any tobacco products. That's pretty much the extent of the question. So you'll have that. It's in there. So if at some point you want to discuss that further, you can reach out to me. You've got my cell number, my email. My cell number is the number, if you call me, is the number to get me on, or text me. Okay? All right. Thank you. Thank you very much. This worked for you.